Welcome students to MBBS online lecture. Today's topic is about cardiovascular module test. We are going to solve the cardiovascular module test which was taken by the alums. There are a total of 100 questions. This video is going to be long, so moving to our first question. A patient with a right heart failure develops edema on the feet. Which one of the following starting forces is most likely disturbed in this patient? A. Lymphatic pressure, capillary hydrostatic pressure, plasma colloidal osmotic pressure, interstitial hydrostatic pressure, interstitial colloidal osmotic pressure. When there is a right heart failure, it will cause the fluid buildup in the systemic circulation or in the veins. So the blood backs up backed into the veins, or we say superior vena cava and inferior vena cava. So when the fluid accumulate in So when the fluid pressure increases, it will cause the capillary pressure to increase, capillary hydrostatic pressure increase, which is caused by the increase in the volume at a certain point. This will cause the outward pressure and causing edema in the feet. So this is going to be the capillary hydrostatic pressure. Question 2 says status of heart valve during a cardiac cycle include heart sounds are produced by closure of valves. All four valves can never be closed together. Valves can open due to backward pressure gradient. Both semilunar valves always close simultaneously. Valves close due to forward pressure gradient. So a simple and statement is that the heart sound are produced by the closure of the valves, such as mitral and tricuspid valves produces first heart sound, while the closure of semilunar valves, which include aortic and pulmonary valves, produces second heart sound. Question number 3 says, what is the advantage of AV nodal delay? Prevent heart from fatigue, increase the strength of heart contraction, allows ventricular filling, prevent heart from arrhythmias, allows atrial filling. So AV nodal delay is a delay between the contraction of the atria and the contraction of the ventricles. So AV nodal delay causes the increased time for the ventricular filling. So this is going to be the option C. Dynamic exchange of capillary level include a dynamics of exchange of at capillary level include plasma colloid osmotic pressure is outward pressure. Hydrostatic pressure is an inward pressure. About 24 liters of fluid are filtered each day. At the venous end of the capillary, outward pressure is more. None of filtered fluid enters the capillaries. It's going to be option C because the option A, B, and D does not satisfy the dynamics of exchange between the which is occurring between the interstitial fluid as well as the intracellular fluid. At so Question number 5 says at J point the electrical potential of a heart is minimum equal to P wave 0 maximum equal to QRS complex. So J point is basically a point which is followed after the QRS complex and it is equals to the zero potential. When we see on the ECG electrocardiogram, we will see note that after the occurring of the QRS complex, there is a point where there is no potential, electrical potential, and that point is called J point. Question number 6 says most important complication of traumatic shock is hepatic failure, muscle injury, renal failure, myoglobinuria, heart failure. Since it's a traumatic shock, in traumatic shock, when there's an accident or any trauma to the body, it can lead to the muscle injury. So this is going to be the B option. When inward pressure causing a resorption of the fluid at the venous end of the capillary is plasma colloid osmotic pressure, blood pressure, interstitial fluid, osmotic pressure of fluid, hydrostatic pressure. So when we look at the dynamics of the capillaries, we note that there are the arterioles, then between the arteriole and venule there are the capillaries where the exchange of material takes place. So in at the level of capillaries and arterioles, all of the fluid filtered out of the capillaries into the interstitial fluid. So the remaining back in the capillaries and arterioles are the large protein that cannot cross the slits-like spaces between the capillary cells or endothelial cells. That's why they remain in the capillaries. So they exert a great pressure which is called plasma colloid osmotic pressure. So this pressure, if it is increased, it causes the reabsorption of the fluid into the capillary. So it is causing about that the main inward pressure. So main inward pressure is the plasma colloid osmotic pressure. The second heart sound is caused by the closure of aortic and pulmonary valves, ventricular filling, vibration in the ventricle during systole, closure of mitral and tricuspid valves, retrograde flow in the vena cava. So option B, option C, and option E are ruled out because they are not causing the heart sound, while the option A and D may produce heart sound. But the second heart sound is produced by the, as we have discussed, these are produced by the semilunar valves, which include aortic and pulmonary valves. Basic abnormality in septic shock is fever, increased cardiac output, increased metabolism, vasodilation, parasympathetic stimulation. So what happens in septic shock? Bacterial endotoxin, which is present in the plasma of a patient, this causes the series of reactions occurring in the person's whole body. So one of the effect is the vasodilation. The vasodilation causes a sudden decrease in the blood pressure and causing abnormal or septic shock. Question number 10 says the immediate compensatory mechanism that normalizes the pressure, capillary fluid shift, CNS ischemic response, renin-angiotensin mechanism, baroreceptor reflex, chemoreceptor reflex. So baroreceptor reflex is the immediate compensatory mechanism that normalizes the pressure, because although the CNS ischemic response is one of them, but the baroreceptor is a neural control of the blood pressure. While we look at the capillary fluid, these are intermediate, and renin-angiotensin is also the long compensatory mechanism. Increasing vagal stimulation of the heart will cause an increase in cardiac output, PR interval, ejection fraction, ventricular contractility, heart rate. When we will see the vagus nerve basically causes the parasympathetic effect on the heart. So when there is a parasympathetic effect on the heart, it will lead to the decrease in heart rate or decrease in cardiac output, decrease in ejection fraction, but increase in the PR interval. PR interval is basically measure of the, when we see the ECG, it will be most of PR interval is used for the calculation of the heart rate. When the PR interval, time between the PR interval is increased, it leads to the decrease in heart rate. So question number 12 says the heart muscle acts as a functional syncytium. This is due to long refractive periods, say SA node, intercalated discs, plateau in the action potential, or conductivity. So the functional syncytium is basically the individual muscles of the individual muscle fiber acting as a single unit. This is the definition of the functional syncytium. So this is in the heart muscle. It is due to the presence of the intercalated disc. The intercalated disc has many of the gap junctions. Gap junction causes the exchange of ions between individual muscle cells and causing them to contract in a sync manner. So moving toward question number 13, semilunar valves close at the onset of rapid filling, isovolumetric relaxation, diastasis, isovolumetric contraction, rapid ejection. So semilunar valves basically close when the ventricle is being contracting, when there is isovolumetric contraction or isovolumetric relaxation. So semilunar valves basically close when there is a isovolumetric relaxation, because isovolumetric relaxation causes the closure of the AV valves as well as the semilunar valves. Now question number 14 says the long-term tissue blood flow will increase by the which of the following mechanisms: rise in temperature of the tissue, accumulation of CO2 in tissue, fall in pH of tissue, formation of new vessels, deficiency of oxygen in tissue. The long-term effect for increasing the blood flow is caused by the formation of new vessels, because all other responses or all other factors causes the short-term tissue flood, short-term increase in the blood flow. So in irreversible shock, ATP is broken down into creatinine, lactic acid, uric acid, AMP, or pyruvic acid. So when there is an irreversible shock, ATP is broken down into the lactic acid. Then there is a accumulation of the lactic acid in the body, because the body is not able to satisfy the needs of the and satisfy the oxygen demand of the body due to the fall in the blood pressure. Now, moving toward question number 16, the ECG of a 45-year-old man shows no P wave and irregular rhythm of 40 beats per minute with a normal QRS complex. The probable cause of this rhythm is increased delay at the AV node, non-functional SA node, stimulation of parasympathetic effect, ectopic pacemaker in the right atrium, complete heart block. So when we need to see that what does the P wave indicates in the ECG. The P wave indicates the atrial systole or atrial contraction. So when there is no atrial contraction, and we note that the SA node is present in the atria, right atrium, wall of the right atrium. So when there is a non-functional SA node, which is the correct answer here, so this causes the no P wave, but there is a QRS complex, normal QRS complex. This is caused by the AV node, the beats or rhythm produced by the AV node, which is the equals to 40 beats per minute. Now, question number 17 shows which of the following events occur at the end of the period of ventricular ejection. AV valves open, AV valves close. Aortic valves open, aortic valves remain open. Pulmonary valves close. So when it is asking about the end of the period of ventricular ejection, so at the end of the period or at the end of the systole, what causes the pulmonary valve basically closes. When a positive inotropic agent is given to the 40-year-old hospitalized patient, the ejection fraction of a patient is increased. An increase in the ejection fraction will cause a decrease in the following variable of the patient: the stroke volume, cardiac output, systolic pressure, and diastolic pressure. So when there is an increase in the ejection fraction, it will cause the decrease in the end systolic volume, because end systolic volume is the volume of the blood that remains in the ventricle after the systole. So when the contraction is increased of the heart muscle, it will cause the more blood to be pumped into the aorta and systemic circuit. So less blood will be remain, or less blood will be present in the ventricle at the end of the systole. So this will lead to decrease in the end systolic volume. Question number 19 says a young man reading a newspaper in a relaxing state. Under normal condition, the vascular resistance can be altered, modified by changing the vessel length, vessel radius, blood viscosity, concentration of plasma protein, hematocrit. So in normal condition, it can be altered by vasodilation or vasoconstriction, which will increase or decrease the vessel radius. Which of the following phase of the cardiac cycle follows immediately after the beginning of the QRS complex? Diastasis, atrial systole, isovolumetric contraction, ventricular ejection, isovolemic relaxation. So we need to see what does the QRS complex basically represent in the ECG. So QRS complex basically represent the ventricular systole or ventricular contraction. So when there is a ventricular contraction, first step in the ventricular contraction is the isovolemic contraction of the ventricles. Isovolemic contraction basically represents the contraction of the ventricles that causes the increase in the pressure, but the volume of the blood in the ventricle remain constant. So I have a figure. You can see here that this period, which is marked by this is showing the ventricular volume. You can see that these are the isovolumetric relaxation. This is the isovolumetric contraction. So when in isovolumetric contraction, there is no change in the ventricular volume. Since this pink graph shows the ventricular volume when there is a constant volume in the ventricular, but the pressure in the ventricle is being increased, while the blue line shows the ventricular pressure. In this section, you can see that the volume of the ventricle remains constant, but the pressure is being increased. This is due to the contraction of the ventricles. Then there is a ejection of the blood, which is due to the systole. So, moving to our question number 21, the nervous regulation of the circulation is achieved by the autonomic nervous system. The following statement correctly describes the effect of autonomic nervous system or activity on the cardiovascular system in a healthy subject. The stimulation of parasympathetic nerve decreases the strength of cardiac ventricular contractions. The stimulation of the sympathetic nerve decreases the strength of cardiac ventricular contractions. Inhibition of parasympathetic nerves increases total peripheral resistance. Inhibition of parasympathetic nerves decreases the total peripheral resistance. Inhibition of parasympathetic nerve increases the heart rate. First, we need to see that there are two types of the autonomic nervous system, which include sympathetic and parasympathetic. When there is stimulation of the sympathetic nervous system, it will cause the increase in the heart rate or increase in the cardiac output. But when there is a effect, or when there is stimulation of the parasympathetic nervous system, it will lead to decrease in the heart rate, so decreasing the cardiac output. But the sympathetic nervous system has effect on heart as well as the vessels, blood vessels, but the parasympathetic nervous system has only effect on the heart. So the stimulation of parasympathetic nervous system has no effect on the total peripheral resistance which is offered by the blood vessels. So when we see that the option E is going to be correct, because inhibition of the parasympathetic nerve increases the heart rate, because the parasympathetic nerve causes the decrease in the heart rate. When we inhibit the parasympathetic nerve, it will increase the heart rate. So question number 22 says a patient with a right heart failure develops edema on which of the following starting forces is most likely disturbed in this patient. So this is the same question we have encountered in the first question in this file. So this is going to be the capillary hydrostatic pressure. Question number 23 says the parent of a young baby had discussion with the pediatric cardiologist. The parents later asked the nurse to explain once again what patent ductus arteriosus is. The nurse explained that it is narrowing of the pulmonary artery, an enlarged aorta and pulmonary artery, connection between the pulmonary artery and aorta, abnormal opening between the right and left ventricle, a shunt between the umbilical vein and inferior vena cava. So patent ductus arteriosus is basically the connection between the pulmonary artery and the aorta. You can see here that these are some questions from the official file of the lumps. It has also options which are already selected, but these do not simply rely on these options, because this can be incorrect. So connection between the pulmonary artery and aorta, I would have a picture. You can see here, this is the patent ductus arteriosus. So this is the aorta, which has the ascending aorta, the arch of aorta, and the descending aorta. And this is the pulmonary artery or pulmonary trunk. So pulmonary artery will divide into right and left pulmonary trunk. So you can see here there is a connection between the aorta and the pulmonary artery. This is called a patent ductus arteriosus. So in patent ductus arteriosus, the blood will move from high pressure such as aorta into the lower pressure circuit, which is the pulmonary artery. So here it is a left to right shunt of the blood. Now moving to our question number 24, the cardiologist vascular system is a major system of the to function in the embryo. Primordial heart and vascular system appear in the middle of the third week, derived from which of the following embryonic tissue? Pharyngeal mesoderm, somatic mesoderm, intermediate mesoderm, splanchnic mesoderm, or somatic mesoderm. Somatic mesoderm. So when we look at the development of the heart in the vascular system, these are developing from the splanchnic layer of the lateral plate mesoderm or splanchnic mesoderm. A premature female infant getting cyanosed while crying and feeding. After clinical examination, diagnosed as a case of patent foramina ovale. This opening is left by which of the following structures? Septum primum, endocardial cushion, septum primum, septum secundum, or bulbar ridges. So this is going to be the septum secundum because the foramina ovale is an opening between the right atrium and the left atrium. So that there is a shunting of the blood from the left atrium into the right atrium due to the pressure gradient. So in patent foramina ovale, the septum secundum is failed to fuse with the septum primum and causing a gap which is called foramina ovale. A newborn infant present with a cyanotic heart disease. On examination, it was revealed that the aorta arose from the right ventricle and the pulmonary trunk arose from the left ventricle. What is the name given to this type of cardiac malformation? Persistent truncus arteriosus, transposition of great vessels, tetralogy of Fallot, VSG or ASG. This is called the transposition of the great vessels when the aorta arises from the right ventricle while the pulmonary artery arises from the left ventricle. I have a figure you can see here. This is the basically this is showing the transposition of the great artery. This is the aorta, but it's in this case it is arising from the right ventricle, while the pulmonary trunk is basically arising from the left ventricle. This is due to the abnormal malformation which is caused by the abnormal formation of the aortic-pulmonary septum. Question number 27 says a newborn baby is present with the craniofacial defects brought to the cardiologist for evaluation of cardiovascular disease or cardiovascular system. Which one of the following embryonic structure contribute to develop craniofacial structure and outflow region of the heart? Pharyngeal mesoderm, endoderm, flanking mesoderm, pharyngeal arches, or neural crest cells. When we look at the craniofacial, or we say the bones and the muscles of the face or skin of the face, it is formed by the neural crest cells. When there is a new defect in the craniofacial structures as well as in the heart, which include the outflow regions of the heart, such as truncus arteriosus. So this is due to the defect in the neural crest cells. 28 says the primitive heart tube develops bulges and constrictions along its anterior-posterior axis. Which part of the heart tube develops smooth part of right ventricle? Truncus arteriosus, sinus venosus, primitive ventricle, bulbus cordis, or primitive atrium. So bulbus cordis basically forms the smooth part of the right ventricle, but more specifically the conus cordis, part of the bulbus cordis, produces the smooth part of the right ventricle as well as the smooth part of the left ventricle. Question number 29 says the ligamentum arteriosum is a remnant duct of the ductus arteriosus. The embryonic origin of the ligamentum arteriosum is from which of the following structures? Artery of second arch, artery of third arch, artery of fourth arch, artery of fifth arch, or artery of sixth arch. When we see the development of the arterial system in the human body, the ligamentum arteriosum or the ductus arteriosus is basically formed when there is a connection between the aorta and the pulmonary trunk, as we have discussed in the previous questions. So this is arising from the sixth aortic arch. So E option is correct. Question number 30 says the developing heart is in very unusual position, cranial to future mouth. Which one of the following event is responsible for the descent of heart into its adult anatomic position? Lateral folding of the heart or embryo, craniocaudal folding of the embryo, programmed cell death, programmed cell differentiation, programmed cell proliferation. So when there is a craniocaudal folding of the embryo, the heart is pushed from the upper region into the thoracic region. Question 31 says a physician monitoring a newborn infant's heart sound characterized by murmur of patent ductus arteriosus. Which one of the following is the remnant patent ductus arteriosus? Ligamentum arteriosum, median umbilical vein, medial umbilical ligament, ligamentum teres, ligamentum venosum. So the option of this question was already discussed in the question of this 29, question number 29, which is the ligamentum arteriosus, is the remnant of ductus arteriosus. So we can here confidently choose the option A. Question number 32 says, in the normally developing embryo, the aortic arches are apparent by the end of the fourth week. Which of the following arteries is derived from a third pair of aortic arches? Carotid, pulmonary, stapedial, subclavian, or umbilical? So the arteries which are arising from third aortic arch are the carotid arteries, which include more specifically common carotid artery and the proximal part of the internal carotid artery. A newborn baby was brought with a poor feeding, shortness of breath, palpitations, and mental retardation. Diagnosis of atrial septal defect due to the failure or closure of ostium primum with a Down syndrome was made. Closure of foramina primum results from fusion of which of the following structures? Septum secundum and fused endocardial cushion, septum secundum and septum primum and fused endocardial cushions, septum primum and the septum superum, septum primum and the sinoatrial valves. It is asking about the closure of the foramina primum. So when there is a closure of the foramina primum, the septum primum basically fuse with the fused endocardial cushion, or we say atrioventricular cushion. So when septum primum fuse with the AV cushion, it causes the closure of the foramina primum. I have a figure. You can see here that the certain phases of the closure of the septum primum as well as ostium primum are displayed here. In the A figure, you can see this is the septum primum, while the foramina it forms the ostium primum. It is not. This is the in the center. You can see it is the AV cushion. So the septum primum is still not attached to this AV cushion. So it forms the foramen, which is called ostium primum. In the B, you can see that the ostium septum primum basically fused with the endocardial cushion, causing the closure of the ostium primum. In C, you can see when the septum primum fused with the AV cushion, a second foramina is formed. We said that this is the ostium secundum. Now, moving toward the question, in the absence of inferior vena cava, blood from caudal part of the body reaches the heart by the way of azygous vein. Name the embryological origin of azygous vein. Posterior cordial, superior cordial, supra superior, subcordial, posterior cordial, and supracordial, sacrocordial. So the development of azygous vein is basically formed by the posterior cordial and the supracordial vein. So when we look at the best choice of the answer, we will tick the option D being the correct answer. 35 says the middle of the sternum at about level of fourth or fifth costal cartilage. If the object also penetrated pericardium and the heart wall, which heart chambers would most likely be damaged? Left atrium, left ventricle, right atrium, right ventricle, right atrium, and right ventricle. Just remember one thing: when there is a penetration of any object in the center, as well as in the fourth or fifth cartilage, or at any level of the cartilage, costal cartilage, but in the anterior part of the thoracic cage, it will always lead to the damage to the right ventricle. So because the right ventricle, majority of the sternal part is formed, costo-sternal part is formed of the heart is formed by the right ventricle. So when there is a object penetrating in the sternum or at any level, it will lead to damage to the right ventricle. Moving toward the physiology section, a patient with a right heart failure develops edema on feet. Which of the following? This is the third time this question is being repeated and is going to be the capillary hydrostatic pressure. 37. In a woman, which of the following will be greater during the plateau phase of the ventricular action potential than the rest? Calcium conductance, sodium conductance, total membrane conductance, potassium conductance, chloride conductance. First, we need to see that in which phase of in which contraction or in which action potential the plateau phase is seen in the heart. So in the contraction of the myocardium, which is the heart muscle, when it contracts, when the action potential is being generated, it will have the plateau phase. In plateau phase, what the calcium conductance is basically increased, which causes the plateau phase. Which of the following is associated with worsening of the shock? Vasomotor stimulation, cardiac excitation, clots in the small blood vessels, sympathetic stimulation, alkalosis. So it's asking about the which of the factor will cause the worsening of the shock. In shock, there is a decrease in the blood pressure. So we need when there is a further decrease in the blood pressure, it causes worsening of the shock. So when there are the formation of the small clots in the blood vessel, so it will lead to reduction in the blood flow and causing the tissue to starve for oxygen. It will lead to worsening of the shock. While the other option will cause the is increased stimulation of the heart and causing pumping and increasing the cardiac output, hence increasing the blood pressure. Question number 39 says the special feature of SA node is it is plateau, it is very prolonged, it has low RMP, it does not hyperpolarize, or it does not hyperpolarize. So when we look at the action potential of the SA node, it does not have any plateau, it is not prolonged, and it does not have a low RMP because it has a RMP of -65 as compared to the RMP of the muscle fiber, which is -85. -85 indicates low value while the -65 indicates high RMP. Other option we left with is the it does not hyperpolarize, so it's going to be the correct answer. The immediate compensating mechanism that normalizes the blood pressure when a person stands up from lying posture is baroreceptor reflex, chemoreceptor, CNS ischemic response, and angiotensin mechanism, capillary fluid shift. This is the repeated question we have discussed previously in previous questions. It's going to be because the immediate compensating mechanism that normalizes the blood pressure is going to be the baroreceptor reflex. During ventricular diastole, the main factor which keeps driving the blood flow forward in an arterial system is the passive distension of the arteries, more opening of the precapillary sphincters, elastic recoil of the arteries, generalized arterial dilation, inertia of blood itself. So when there is a start of the ventricular diastole, the blood always keep flowing into the arterial system. This is due to the inertia of the blood itself because the heart is not pumping while the ventricle are being relaxed, but the blood does not backflow into the ventricle. It will continue flowing into the arteries and veins. Sorry, in arteries only. The blood flow in a given vessel will greatly increase by doubling the. Okay, in question number 41, this condition is basically called the protodiastole. So moving to our question number 42, the blood flow in a given vessel will greatly increase by doubling the pressure gradient, blood viscosity, blood velocity, arterial radius, or blood volume. So when we increase the blood flow, increasing the blood flow, we need to increase or decrease the arterial radius. When there is a decrease in the arterial radius, it causes the more blood pressure because the blood will exert more pressure on the walls and it will lead to increase in the blood flow. So arteriolar radius is basically the factor which governs the blood flow in the vessel. So question number 43 says CNS ischemic response is emergency mechanism, BP control, stimulation when BP falls to 100 or 80 millimeter of mercury, associated with powerful vasodilation, responsible for to cause increasing urine output is due to increased blood flow to brain. Again, CNS ischemic response is basically the emergency mechanism of BP control. So in CNS ischemic response, what happens? There is a decrease in the blood flow towards the brain or into the cerebrospinal fluid. So there is accumulation of the so there is a start of the anaerobic respiration, which will cause the accumulation of lactic acid, which will cause the decrease in the pH. So decrease in the pH will cause strong stimulation of the baroreceptor reflex. So in baroreceptor reflex, it will lead to vasoconstriction of the peripheral arteries. So when there is a vasoconstriction, it will lead to increase in the blood flow towards the brain. So physiological causes of edema include increased hydrostatic pressure, increased colloidal osmotic pressure, increased capillary permeability, vasodilation, sympathetic stimulation. So what basically edema is? In edema, it is basically the outward flow of the fluid into the interstitial fluid and interstitial compartment. This is due to the increase in the capillary hydrostatic pressure. But in these options, it is not given, so it's going to be the increased capillary permeability also causes the edema. This is the case in the septic shock, so it's going to be correct answer. Maximum oxygen consumption of the myocardium occurs during isovolemic contraction, period of rapid ejection, period of slow filling of ventricles, isovolemic relaxation, period of rapid filling of the ventricles. So when there is an increase in the workload of the on the myocardium, it will lead to increase in the oxygen demand. So and hence oxygen consumption. So in the rapid ejection, the myocardium is working very hard, which will cause the increase in the oxygen demand for the myocardium and causes maximum oxygen consumption. Heart muscle acts as a functional syncytium. This is due to the SI node, intercalated disc, long refractory period, conductivity, plateau, and action potential. We have discussed this question previously. It is going to be the intercalated disc. This is due to the presence of gap junction in the intercalated disc. So moving to our question number, sorry. So moving to our question number 47, long refractive period protects the heart from excessive fatigue, infarction, arrhythmias, failure, or AV blocks. So long refractive period is also the property of the myocardium and it protects heart from the excessive fatigue. Feature of conducting system of the heart include it is located in the myocardium. Its all part can generate impulses. Purkinje fibers have the lowest conductivity. AV node is the normal pacemaker, while the AV bundle has the highest conductivity. So the feature of conducting system is also included that its all parts can generate impulses, because when there is a block in the SA node, when the SA node is non-functional, the AV node starts generating the impulses, which are the 40 beats per minute. When the AV node is blocked, the Purkinje fibers also generating impulses, which is equals to 15 to 30 beats per minute. So features of various types of heart block include most common side of heart block is the SA node. In first degree heart block, PR interval is decreased. In second degree heart block, dropped beat occurs. In third degree heart block, ventricular rate 72 beats per minute. AV node is the very rare side heart block. So both A and E are incorrect because they are contraindicating each other, while the in first degree heart block, PR interval is basically increased, while in second degree heart block, dropped beat occurs. So it's going to be correct answer is C. While in third degree heart block, there is a complete block in the atria and ventricle. So the ventricle atria contract at its own pace while the ventricle contract at its own pace. So option C is correct. I have a figure of the electrocardiogram. You can see that the second type of heart block or second degree heart block is also called the Mobitz Type 2. In this you can see there is a no conductance in the QRS complex. There is a contraction of the atria which is shown by the P wave, but there is no contraction in the ventricle. So it is causing the dropped beats. In Stokes-Adams syndrome, person become unconscious due to head injury, a complete AV block, ventricular fibrillation, electrical shock, or mitral regurgitation. Stokes-Adams syndrome is also related to the second degree heart block when they are the dropped beats. So, or we say there is a it is also related to the third degree heart block when there is a no contraction or there is a complete block in the conductance of from the atria into the ventricle. So the ventricle does not contract after the atria contraction. So in this case that the So when there is a complete block in the AV or third degree heart block, so the ventricle does not contract and then it does not pump blood into the systemic circuit. This causes the call stroke or the decreased blood supply towards the brain and causing infarction of the brain. So this is caused by the complete AV block. 51 says which are the following the hemodynamic change in the aortic stenosis and aortic incompetence: decreased blood volume, increased stroke volume, left ventricular hypertrophy, right ventricular hypertrophy, hypertension. When we look at the aortic stenosis and aortic incompetence, it is caused by the aortic stenosis is basically refers to the inability of the heart valves, aortic valves to open, while the aortic incompetence refers to the inability of the heart valves to close. So they remain open throughout the cardiac cycle. So the effect of these two conditions on the heart is basically is the left ventricular hypertrophy, because the heart needs to pump harder in order to pump blood into the systemic circuit. This increased workload on the myocardium can lead to hypertrophy of the heart, particularly in the left ventricle, because the aortic valves are located in the left ventricle. Most significant physiological abnormality in tetralogy of failure is left ventricular hypertrophy at ASD, right to left shunt, pulmonary hypertension, or systemic hypertension. So when we look at the tetralogy of Fallot, it has the physiological abnormality in the pulmonary hypertension. There is a pulmonary hypertension. I will explain why the pulmonary hypertension occurs in the tetralogy of Fallot. I have a figure you can see here that there are basic four major defects in the tetralogy of Fallot. That's why it is called tetra. Tetra means four. One shows the pulmonary stenosis. Second is the right ventricular hypertrophy. Third is the overriding of aorta. Fourth is the ventricular septal defect. You can see here in these figures, the pulmonary hypertension is due to the pulmonary stenosis. As we have discussed in the previous question, that the aortic stenosis causes the systemic hypertension and lead to left ventricular hypertrophy. But in pulmonary stenosis, it will lead to the pulmonary hypertension and will lead to the right ventricular hypertrophy. That's why due to the pulmonary stenosis, the right ventricular hypertrophy occurs. So pulmonary stenosis, as you can see here, this is the narrow opening or the narrow opening into the pulmonary trunk. So the blood pump, this heart need to pump harder in order to pump blood into the pulmonary circuit. That's why there is a pulmonary this is due to the pulmonary stenosis, which causes the pulmonary hypertension also. Which are the following decrease in the circulatory shock: aldosterone, methatrexate, ADH, angiotensin 2, or ANP? ANP is a atrial natriuretic peptide hormone which is decreased in the circulatory shock. ANP basically causes the decrease in the blood pressure, but in the circulatory shock we need to increase the blood pressure. That's why the ANP is decreased. This is also the compensatory mechanism. Compensating mechanism of circulatory shock include decreased aldosterone, parasympathetic stimulation, decreased ADH, baroreceptor reflex, or increased ANF. In circulatory shock, we don't need to increase the ANF because atrial natriuretic peptide will cause the decrease in the blood pressure. While the baroreceptor reflex, stimulation of the baroreceptor reflex will cause the immediate increase in the blood pressure and causing compensatory mechanism, the circulatory shock. So D is going to be correct answer. Moving to our question number 55, coronary artery disease is the most common cause by the arteriosclerosis, thrombus formation, embolia, vasospasm, vasoconstriction. So atherosclerosis is basically the most common cause for the coronary artery disease. This is due to the formation of the plaque in the coronary artery. I figure you can see here that so you can see here this is the basically formation of a plaque in the lumen of the arteries, further causing the decrease in the blood flow, which will lead to the coronary artery disease. So bend bridge reflex prevents cardiac contraction, cardiac excitation, damping of the blood, increase BP, decrease BP. So band bridge reflex is basically also the subtype of the baroreceptor reflex. So it is due to the when there is an increase in the volume of the blood or congestion of the blood in the arteries or in the heart will cause the This will lead to the increase in the heart rate. So increase in the heart rate causes the decrease in the damming of the blood or the accumulation of the blood in the systemic circuit. So blood will move more. So the Denbury reflex prevents damming of blood. Is released from kidneys in response to. So it is basically asking about the erythropoietin. Erythropoietin is released from kidneys in response to increased BP, increased blood volume, increased ECF volume, ischemia, hypoxia. So hypoxia is basically the factor which causing the kidneys to increase the release of the erythropoietin, which will lead to the increase in the RBC volume. CNS and ischemic responses. This is also the repeated question and is going to be the correct answer is A. Question number 59. If the stroke volume increase maintaining the cardiac output, A, heart rate must decrease, heart rate must decrease, heart rate must increase, rate must decrease, and diastolic volume must increase and systolic volume increases, venous return must increase. When we look at the formula of the cardiac output is basically equals to the stroke volume or we say stroke volume multiplied by the heart rate. So if we maintain the cardiac output to be constant, and the stroke volume is also increased, so heart rate must be decreased. If one factor increases, other factor must decrease to maintain maintain constant cardiac output. So B option is correct. Which of the following sequence places the lipoproteins in order from most dense to least dense? A, B, C, or D? HDL, VLDL, chylomicron, LDL, HDL, LDL, VLDL, chylomicrons, LDL, chylomicrons, HDL, VLDL, VLDL, chylomicrons, LDL, HDL, HDL, IDL, LDL, VLDL, chylomicrons. When we look at the lipoprotein from most dense are the high density lipoprotein, which its name indicates that these are the high dense, while the other are the intermediate dense high lipoprotein. Then there is a low density lipoprotein, then the very low density lipoprotein, and the chylomicrons are basically the least dense lipoproteins. Option D is correct. D, sorry. Fatty acids are transported from the adipose tissue to liver bound to the LDL, VLDL, albumin, fatty acid binding factor. Remember that the fatty acids are not transported into the lipoprotein, these are transported by the binding to the albumin, which is a plasma protein. Question number 62 says the triglycerides present in the plasma protein are primarily hydrolyzed by the lingual lipase, lipoprotein lipase, pancreatic lipase, phospholipase, gastric lipase. In the blood or in the adipocytes, the lipoprotein lipase is the enzyme that causes the hydrolysis of the lipoprotein into its components. The form in which dietary lipids are packed and transported from intestinal mucosa to the liver is free fatty acids, mixed micelles, free triglyceride, or chylomicrons. So the lipids that are basically absorbed into the ileum, or we say into the small intestine, these are basically packed into the lipoprotein, which is basically type of chylomicrons. So when these are packed into the chylomicrons, they are absorbed into the blood and they are transported toward the liver. The cardiologist consultant delivered a lecture in the seminar on preventive measurements of myocardial infarction and other cardiology disease. He advised the community to use the fish liver oil, etc., because it contains good amount of omega-3 fatty acids, which are highly protective against cardiac disease. Which omega-3 fatty acids present in the fish with good quantity? Folic acid, linolenic acid, linoleic acid, docahexanoic acid, or arachidonic acid. So omega-3 fatty acids are the linolenic acids as well as the docahexanoic acid. But in the fish, there is a specific source which is asking about the fish. In fish, the docahexanoic acid is present in good quantity. Question number 65 says a 40-year-old British man underwent gene therapy for acute myeloid leukemia and has been treated for both AML and HIV-1. Which of the following hydrolytic enzyme was used for this treatment? Proteases, phosphatases, lipases, aminotransferase, nuclease. When we look at the treatment of cancer cells or the HIV cells, human immunovirus, when we look at these cells, we need to destroy their nuclear proteins, which include the DNA or the type of protein. When we destroy the DNA of these proteins, it will lead to the apoptosis of these cells. So nucleases are basically the enzyme which are used to ligase, or we say hydrolyze the nuclear proteins. 66 says that 25-year-old man, no known case of a GSD, glycogen storage disease, is inherited defect of the lactate dehydrogenase enzyme. Which of the following classes of enzyme this enzyme belongs? Oxidoreductase, transferases, hydrolysis, isomerases, ligases. So lactate dehydrogenase, when there is a dehydrogenase, it basically refers to the enzyme which removes the hydrogen ion or hydrogen atom from any other compound. So when there is a removal of hydrogen atom, the process is called oxidation. So these are classes of enzyme which belong to the oxidoreductase. A child took sugarcane subject juice, regarding which of the following matches is correct? Separate protein enzyme pepsin, separate lipid enzyme lipase, separate starch enzyme amylase, separate sucrose enzyme invertase, separate glucose enzyme glucokinase. So when we look at the sugarcane is basically rich in the separate sucrose, which is a non-reducing sugar. So the enzyme used for the digestion of the sucrose is the enzyme invertase. So option D is correct. A 3-year-old Negro girl has an inborn error of protein metabolism. The enzyme deficiency normally works by decrease in the energy of reactant, decrease in the activation energy of reaction, decrease in the activation energy of reaction, increase in the activation of energy of reaction, decrease in energy of product, decrease in transition energy of reaction. We know the action of enzyme, basically it causes the decrease in the activation energy of reaction, which causes less amount of activation of energy required to initiate any reaction. Question number 69 says, how many IPP, or we say isopentyl pyrophosphate molecules are required for the formation of squalene? 4, 5, 7, 6, 2. When you look at the structure of the squalene, it consists of the 30 carbon atoms, while the isopentyl pyrophosphate, pentyl refers to the 5 carbon atom. So IPP consists of the 5 carbon atoms. When we need to add enough amount of IPP molecules to form the 30 carbon squalene. So 5 multiplied by 6 is equals to the 630. So there are the 30 molecules, or 6 molecules of IPP are required to form this 30 carbon squalene. So 70 says, which of the following enzyme is responsible for the conversion of cholesterol ester inside the cell? Lecithin, cholesterol acyltransferase, acetyl cholesterol acyltransferase, cholesterol esterase, both A and B, HMG covalent synthase. A option is correct, which is lecithin cholesterol acyltransferase, which is also called LCAT enzyme. LCAT causes the formation of the cholesterol ester from cholesterol. So cholesterol are reacted with the lecithin to form the cholesterol ester and lysolecithin, which is catalyzed by enzyme LCAT. Sterol regulatory binding protein binds with DNA and the sterol regulatory element to increase the expression of the HMG CoA reductase and synthesis of cholesterol. The presence of high cellular concentration of cholesterol increases the proteolytic cleavage and release shuttling of the SREBP into the nucleus. Decrease the proteolytic cleavage and release of SREBP from ER, activates SREBP by inducing the conformational change, inhibit SREBP by competitively bind to DNA binding site of the SRBP, decrease the proteolytic cleavage and increasing the phosphorylation of HMG CoA reductase. So sterol regulatory element binding protein, basically the protein factor which is regulating the synthesis of the cholesterol. So when there is an increase in the cholesterol, there is no proteolytic cleavage of the sterol, or we say SREBP. When there is a decrease in the cholesterol, there is a more proteolytic cleavage of the SREBP, which causes the increased expression or increased activity of HMG-CoA reductase. So in case of high cholesterol, there is a decrease in the proteolytic cleavage and there is no release of SREBP from endoplasmic reticulum. An activated enzyme made up of polypeptide chain in a cofactor is called coenzyme, substrate, apoenzyme, holoenzyme. So enzyme which is called apoenzyme with its cofactor forms the holoenzyme. Which of the following property is not exhibited by the enzymes? Electrophoretic mobility, different kinetic properties, sigmoidal shape curve arise from different genes, amino acid sequence. So sigmoidal shape curve is not exhibited by the enzymes, while the other forms of such as amino acid sequence and arise from different genes as well as different kinetic properties, and they are the electrophoretic mobility in the enzyme. These are exhibited by the enzyme, but the sigmoidal shape is not exhibited by the enzyme. I have a curve shown here which shows the energy and the reaction rate of reaction of the enzyme catalyzed reaction. You can see here this is not a sigmoidal shape curve. So which of the following inhibits cholesterol synthesis? Insulin, T3, intake of calories, both A and B, and none of the above. So in this question, we want to inhibit the cholesterol synthesis. Insulin, while thyroxine and intake of or excess of calories basically increases the cholesterol synthesis. So the option here is none of the above. Which are the following steps is the regulatory step of cholesterol biosynthesis? Formation of 3-HMG-CoA, formation of mevalonate, formation of isoprenoid unit, formation of inosterol, lanosterol, formation of acetoacetyl-CoA. So formation of mevalonate is basically a regulatory step of the cholesterol biosynthesis, which is catalyzed by the HMG-CoA reductase. The HMG is basically HMG-CoA is converted into the mevalonate. Moving toward the pathology section, role of the neurohumoral system in the compensatory phase lead to the release of dopamine, release of norepinephrine and activation of renin-angiotensin aldosterone system, release corticosteroids, release salt and water from kidneys, proliferation of myocardium. So neurohumoral system is basically compound system of the compensatory phase in the maintenance of the blood pressure. It will lead to release of the angiotensin as well as the norepinephrine. Left-sided heart failure most lead to the pulmonary congestion, ventricular failure due to lead to organ dysfunction, pedal edema, nutmeg liver, jugular venous congestion, facial congestion. When you look at the left-sided heart failure, there is a pulmonary congestion, not the pedal edema or systemic edema, because the blood is backed into the pulmonary circuit. I have a figure you can see here in the left-sided heart failure. This is the left ventricle. When the left ventricle is non-functional, the blood backs up into the left atrium, from left atrium into the pulmonary arteries, and these pulmonary arteries will lead towards the lungs. So these causes the congestion in the pulmonary circuit, or we say in the lungs, leading to pulmonary edema. Cardiomyopathies and ischemic heart disease may cause ventricular dilation, systolic failure, cardiac arrhythmias, diastolic failure, age-related changes. Cardiac myopathies and ischemic heart disease, also called the myocardial infarction. These lead to the systolic heart failure. Which of the following is the earliest complication of myocardial infarction? Ventricular rupture, pericardial effusion, arrhythmia, capillary muscle dysfunction, or stroke. The first complication in the myocardial infarction is the arrhythmia, because we will see that detects changes in the ECG. In ECG, there is a T wave inversion as well as new Q wave formation, ST segment elevation or depression. These are the changes that lead to the arrhythmia, which are the earliest complication of the myocardial infarction. Question number 80 shows which of the following is considered the first cellular event in the progression of the arteriosclerosis: macrophage transformation, monocyte transmigration, smooth muscle migration, endothelial cell dysfunction, or electrophilic infiltration. first cellular event in the formation of the arteriosclerosis is basically the endothelial injury. Endothelial injury causing the increase in the gaps between the endothelial cells, which lead to the accumulation of LDL molecules. So endothelial cell dysfunction is the first cellular event. Which of the following is a not risk factor for the atherosclerosis? Familial hypercholesteremia and ovarian cancer, cigarette smoking, hypertension, diabetes mellitus. So ovarian cancer is basically not related to the arteriosclerosis. Regarding microscopic feature of atherosclerosis, all of the following are true except shoulder area comprising of macrophage and T cells, necrotic core comprising cholesterol and cholesterol esters, area of new vascularization to the sides of the fibrous cape being the most superficial portion, or proliferation of small vessels at the periphery of lesion. So when we look at the histology or the microscopic features of the arteriosclerosis, the proliferation of the small blood vessels is not seen in the peripheral region or in the arteriosclerosis. While they are the formation of new blood vessels, the fibrous cape is the most superficial portion of the atherosclerotic plaque. Necrotic core comprising of the cholesterol and cholesterol ester. This is due to the oxidation of the LDL molecules. Shoulder area comprising of macrophages and T cells. And this is the chronic disease or chronic complication. The macrophages and T cells are the major cell that form cells. So I have a picture you can see here. This is shown the atherosclerotic plaque in the coronary artery. You can see this lining is the fibrous plaque, which is the most superficial portion. Now beneath the fibrous cap there is a molecules of the cholesterol and the cholesterol ester, which is due to the oxidation of the LDL molecule by the macrophages. Now the macrophages and T cells are located in these cells, and there is a proliferation of the small blood vessel into these necrotic cores. The most common trisomy associated with congenital heart disease is trisomy 13, 15, 21, or 18, 19. So congenital heart disease is also related with the Down syndrome, which is a common trisomy. Which one of them is not actually included in tetralogy of Fallot? VSG, subpulmonary stenosis, and aorta that overrides the VSG, patent ductus arteriosus, right ventricular hypertrophy. So when we look at the tetralogy of Fallot, there is no patent ductus arteriosus in the complication of the tetralogy of Fallot. I have a picture which is the same. These are the four factors or four major defects in the TOF, which include pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, ventricular septal defects, but there is no patent ductus arteriosus. Now, HMG-CoA reductase inhibitor are products and must be converted in the GI tract to an active compound. These include atorvastatin, servastatin, fluvastatin, pravastatin, simvastatin. So the inhibitors of the HMG-CoA reductase that is the key regulatory enzyme in the biosynthesis of the cholesterol or lipid lowering drugs. These are the products. It's asking about the products between these options. So we need to choose the product. When we look at the statin, the simvastatin, basically the product. Product means refers to the inactive drug. Nicotinic acid in large doses used to treat hyperlipidemia causes a cutaneous flush. The vasodilatory effect due to release of histamine, production of prostaglandin, production of nitric oxide, calcium channel blockade, release of PDGF. Nicotinic acid or niacin, which is a vitamin B3. It is also used to treat the hyperlipidemia. It causes the inhibition of the lipoprotein lipase. So it has a side effect which is called a niacin flush. It is due to the production of the prostaglandins. The effectiveness of nitroglycerin in the suppression of angina pectoris is due to the reflex inhibition of sympathetic system, arterial vasodilation, redistribution of coronary blood flow, venous vasodilation, negative inotropic effect. So nitroglycerins are basically used for the patient of the angina. It is due to use to the increase the vasodilation. But in these increase the vasodilation in the arteries. Nitroglycerin vasodilator agent acts by decreasing CMP, increasing CAMP, increasing CGMP, decreasing CGMP, or inhibiting nitric oxide. So nitroglycerin basically causes the increase in the cyclic GMP, which causes the contraction or relaxation of myosin light chain kinase. Nitrates are always prescribed with the calcium channel blockers for the treatment of angina pectoris because they increase heart rate, increase end-diastolic pressure, increase contractility, decrease ejection time, or decrease heart rate. It's asking about the effect of the calcium channel blockers. Calcium channel blockers basically include dihydropyridine or non-dihydropyridine. These causes a decrease in the heart rate. Most frequent adverse effect of calcium channel blockers verapamil includes constipation, dry mouth, hysteria, hypokalemia, or tachycardia. Constipation is a major side effect of the calcium channel blockers, specifically verapamil. Most frequent adverse effect of the captopril includes constipation, angioedema, hysteria, hypokalemia, or tachycardia. Captopril is basically are the ACE inhibitor or which is angiotensin converting enzyme inhibitors, which include the lisinopril, enalapril, or captopril. So the major side effect of these drugs includes the angioedema, as well as they can cause the dry cough. Calcium channel blockers with both vasodilator as well as cardiodepressant effect include dioxide, amlodipine, hydrolazine, nifedipine, or verapamil. Remember, there are the two types of the drugs in the calcium channel blockers. These include dihydropyridine as well as they are the non-dihydropyridine. The drugs present in the dihydropyridine ends in the suffix which include dipine, such as amlodipine, nifedipine, nicardipine. So the dihydropyridine has a major effect on the blood vessels only, while the non-dihydropyridine, which include the verapamil and diltiazem, they have the effect on heart as well as the blood vessels. So here we will choose the answer verapamil. Angiotensin receptor blocker used to treat the patients of hypertension includes captopril, hydrolazine, esmolol, losartan, verapamil. Angiotensin receptor blocker or in short called the ARBs. These include the drugs candesartan, valsartan, rosartan. So losartan is basically the drug. These include in the suffix sartan. So D option is correct. According to the classification of the obesity, overweight is considered if BMI 25 to 30, BMI 25 to 29, BMI 18 to 20, 21 to 24, or 24 to 28.9. This is a simple question which include the option A to be correct because the BMI over 25 to 30 is considered as obese or overweight. The modifiable risk factor associated with coronary heart disease is age, obesity, hereditary, genetic, or family history. It's asking about the modifiable which can be changed or which can be controlled, which include the obesity. Obesity can be controlled, while the age and hereditary, genetic, and family history are the non-modifiable risk factor. Which of the following is the purpose of primary prevention of hypertension? To do all the measures to reduce the incidence of the disease in the population by reducing the risk of onset, to prevent the recurrence of the progression of CHT, to prevent the complication, to diagnose the high risk population, to identify the hypertensive patients. Option A is correct in here. A total level of cholesterol to HDL ratio recommended for the coronary heart disease prevention is less than 3, less than 4.5, less than 3.5, less than 2.5, less than 2.0. So the total ratio of cholesterol to HDL ratio less than 3.5 is recommended for the coronary heart disease prevention. 1998 says the which of the following lifestyle intervention for the reducing hypertension most likely to be effective than other: dietary salt restriction, cessation of smoking, intake of fresh fruit, physical activity, or weight loss. When we inhibit the intake of the salt restriction in our daily diet, this is the most effective lifestyle changes in the prevention of the hypertension. During cardiac surgery, cardiovascular surgeon use the transverse pericardial sinus to ligate the coronary artery. Transverse pericardial sinus is located posterior to ascending aorta, anterior to ascending aorta, anterior to left atrium, posterior to left atrium, posterior to esophagus. So transverse pericardial sinus is basically located posterior to the ascending aorta. I have a figure, you can see here that this is the posterior aspect, posterior surface of the heart shown in this figure. You can see this is the transverse pericardial sinus. These sinuses are formed by the reflection of the visceral pericardium on to form this parietal pericardium. Now they are the transverse pericardial sinus. This is the oblique pericardial sinus. So you can see that if we look at heart from the anterior side, this is the ascending aorta. This is the arch of aorta, while this is the descending ascending aorta, while this is arch, this is the descending aorta. When we look at the pericardial sinus is located posteriorly to the ascending aorta. Question number 100, which is the last in this file. A 55-year-old male has been suffering from an embolism of the circumflex branch of the left coronary artery. This condition would result in ischemia of which of the following areas of the heart? So when there is a blockage in the circumflex branch of left coronary artery, the major part of the heart that is deprived of the oxygen is going to be the anterior part of the left ventricle. So anterior part of the left ventricle is basically supplied by the left coronary artery, which is more specifically the circumflex branch. So blockage of this artery can lead to the anterior part of ischemia of the left ventricle. So that was the last question. We have completed our cardiovascular system. We have explained and discussed each and every question in detail with explanation. If you have any query, you can contact us on our email address, which is lumsonline2021@gmail.com. We have also been working on our Facebook page. Make sure you like our page, as well as we have a web page which is you can visit by going towards the www.mbpsonlinelecture.weebly.com. There you can get the lectures from LECTURIO, Osmosis, KENHUB, which are premium and free to download. There is no fees for accessing these lectures. They are the video lectures. They are the concise notes that helps in your annual exam as well as module exam. There are the quizzes for the practice. Thank you for watching. We'll see you next video.